Thank you, Mark. Hello, everyone. Everybody surviving okay? Ready for a little post-lunch siesta? Well, we'll see. I will try to keep you awake. But if you drop off, just stay semi-alert, because I'll alert you to the things that I think are really worth paying attention to, so you at least go home with that amount of information. Lyme disease is not quite the bane of my existence, but it certainly keeps me busy a lot, and I think probably keeps you all busy as well, because although there are straightforward cases, it seems like the non-straightforward cases predominate, at least in my mind. And what I'm going to try to put together for you today is not necessarily the basics of Lyme disease. Certainly if you've been practicing in this area for more than a few years, you've probably seen your share of typical Lyme disease, and I'm going to also provide you with some websites that are useful to get the basic foundations, but we're going to concentrate a little bit on some of the pitfalls, not all of which are completely avoidable, but hopefully develop some strategies for you to deal with that, and maybe some things to iron out. And then, of course, when all else fails, certainly refer to our ID division, but I think I'm hoping this will help you somewhat. So we're not, is the pointer showing up? Yeah. We're not so much going to talk about the basics here. This is, of course, a child. It wouldn't be on this slide unless it were a picture of erythema migrans. It was actually a young girl from several years ago admitted to Children's National for cellulitis. And I guess it was a little more in the early days of Lyme disease, not too well appreciated. But in fact, she had erythema migrans, and she had what's called disseminated erythema migrans, because she had a few more scattered, smaller lesions throughout. And that can be a little tricky, I guess. But this is the one situation that if you're really positive it's erythema migrans, no further testing is needed and only treatment. But again, we're not going to dwell too much on that, although certainly plan to have time for questions at the end. This is the latest data from the CDC, calendar year 2010, and we're here. And I'm always telling the medical students and residents, the DC area morbidly is a great place to practice infectious disease, because everything comes here, including, of course, all the international cases. So I really have to keep on my toes. But it's basically 3 geographic areas, and we're definitely in a hotbed. These are also the most recent CDC data up to 2010. Things vary a little bit, so I'm not sure whether things are increasing or staying relatively the same, but this gives you the broad idea. And then I thought I'd just put in here 3 states, Connecticut, Maryland, and Virginia, to get you an idea of perspective. Have no idea why there was such a drop in Connecticut a few years ago. Again, it doesn't seem to necessarily coincide with any tick seasons or things like that. And there are a lot of things that can affect disease reporting, especially when you're dealing with relatively small populations at the state level. This was a map recently from the Virginia Department of Health, just showing, although Virginia overall is at a relatively low level, in the R area tends to be a little more Lyme disease sort of spilling over, but other areas of Virginia have virtually none. So, what we're going to do, 3 things that I hope will make sense by the end. We're going to talk about the actually limited number of clinical presentations that Lyme really does. And we're going to talk about testing. I wish we had better diagnostic testing, but the fact is we don't. And there are no miracles on the near horizon anyway for diagnostic testing. So we'll talk a little bit about the pitfalls of that. And then we'll talk about the so-called chronic Lyme disease and maybe some strategies to deal with that. So, and this is where you sort of want to pay attention, at least just to the title of the slides and the main colorful things here. So there are basically only 4 clinical forms of Lyme disease. So that's relatively easy. Skin, and you saw a picture of erythema migrans, disseminated erythema migrans, which is not necessarily a worse disease, but can be more confusing. Erythema migrans classically is at least 5 centimeters in diameter. The disseminated lesions, multiple smaller lesions, as I said, can be smaller and not necessarily with central clearing or intensity. So that can be a little confusing. Rarely there's a papule in the center of these lesions, which might represent a bite site. Nobody's too sure. Rarely erythema migrans can be pruritic. Rarely can be versicular. So there's some pitfalls in there, but the classic erythema migrans is pretty noticeable, unless it's in the hair or something like that, where it's pretty easy to miss. Cardiac. In the initial reports of Lyme disease, it appeared that cardiac disease was much more common than we see now. And the main form is with AV block, 2nd or 3rd degree block. And also myocarditis occasionally. For the most part in Lyme disease, if you're treating Lyme disease such as erythema migrans or arthritis or anything, there's no need to go out of your way to look for cardiac disease. The one thing I do is very carefully and intentionally, anytime I'm considering or evaluating a patient for potential Lyme disease, is I palpate the pulse for a good minute, looking at my watch. So I'm making sure there are no arrhythmia skip beats. In general, if you treat the Lyme disease, if they've got 1st degree block, it's going to go away. And if it goes away with treatment, I don't really care if they had it. So, and the cardiologists make enough money anyway, so they don't need it. 3rd form is neurologic. And I like to think of it as classified into peripheral or central nervous system. In terms of the peripheral forms, there is a radiculopathy, sort of myelitis, cranial neuropathy, although it's cranial, it's really belongs in the peripheral nervous system because it's most commonly, as you know, a peripheral 7th nerve palsy. So it's very important to differentiate central from peripheral 7th nerve palsy. Peripheral involves, it's sort of the opposite of what you think, but peripheral, there is involvement both of the forehead and the lower face have impaired movement. And then mononeuropathy multiplex, which is some collection of weird sensory things. The most common is so-called stocking and gloves distribution, where you can have paresthesias, other abnormal sensations in a stocking or glove situation, which actually involves a few adjacent dermatomes. And then CNS, lymphocytic meningitis, and sometimes that's manifest as headache and not much else, or even encephalomyelitis with altered mental status, although that appears to be uncommon. Also note that with the central nervous system involvement, kids more so than adults can develop increased intracranial pressure, so it's always a good idea to try to do a good fundoscopic exam if you're thinking about CNS Lyme. And then arthritis can be mono or oligoarticular, but although I haven't run the numbers, certainly by far the most common cause of monoarticular knee arthritis at Children's National is Lyme disease. So that's sort of a classic, and it's sort of indolent compared to bacterial arthritis or rheumatic fever or other things. So looks pretty swollen, but often the kids aren't in as much pain as you might think, and it's not a red-hot thing. They do pretty well with treatment if you catch it. If it's not caught, then there can be relapsing, remitting arthritis and sometimes chronic joint disease. But in general, with all of Lyme disease, if it's caught early in children, they do very well. I show this slide for sort of a reminder that obviously this is a summer disease, and we're coming into those times. But also there can be presentations at any time of the year, and especially, for example, this arthritis curve that's the solid line, we see plenty in the winter months. And when I'm talking to patients with a monoarticular arthritis, I'm not just asking them about rash in the past few weeks, but really rash in the past year, and ask them to describe it for me. All right, so let's, and I will say, feel free to like shout out or dash up to the microphone or whatever. Interruptions are fine, although I hope to leave a little time for discussion here. But hopefully you've got the 4 clinical areas of note, and that's one of the take-home messages here, and then we'll go into some of the details with testing. So the first pitfall is testing someone for Lyme disease who doesn't have all of those things we just went over. And it's sort of easy for me to say, don't test anybody else, but you and I both know that that just isn't possible. Families, whatever, or neighbors, who knows what, are worried about Lyme disease in this area, no matter what the clinical presentation is. If you're not sure about a diagnosis, got to test for Lyme. And at some point, you can discuss not testing, but at some point, I think kids with some of these other complaints are going to get tested for Lyme. I used to feel bad about that. I don't feel bad about it anymore. I've gotten over that. But I think what you need is a plan. What if, when you order tests on kids whose current clinical symptoms aren't really compatible with Lyme disease, what are you going to do if the test comes back positive? And I think having a plan in advance for each patient is sort of where you can be more proactive with this. Which leads us to pitfall number 2. Since I've been doing more outpatient infectious disease lately, primarily at Holy Cross, seeing a number of kids who got tested for sort of vague complaints and were told they had a positive Lyme test when in fact it was probably a false positive. I actually sort of like to see those because I can usually look like a hero and say, oh no, it's not Lyme. Of course, sometimes they don't believe me anyway, but at least I come up with an answer as opposed to the ones that I don't. So let me explain. What you want to do is a 2-tier test. the first test, if we had the perfect test, we wouldn't be doing it like this. And it looks like we don't quite have the perfect test yet. So depending on where you order your labs, this will be called different things. Sometimes it's a reflex Lyme serology or something. But what it means is you first get an enzyme immunoassay test, which is very highly sensitive. So you're not going to miss much Lyme disease there. But the problem with very sensitive tests is there are false positives. So you get that first test. If it's positive or equivocal, then you get the backup Western blot, which is a little more specific. So, and most of the labs have the ability that, the reflex test, if the EIA is positive or indeterminate, they will automatically continue on with the Western blot. The problem is, it's turned out, maybe over the past 10 or 15 years, it's very clear that there are a number of things, including some not well understood, that can produce a false positive Western blot IgM. And what happens, and I used to do this myself, I would say, I don't want to do 2 steps. If I'm strongly suspicious of Lyme disease, I'm going to outsmart those laboratories that just want to make money by doing more tests, and I'm going to go directly to Western blot. But I quit doing that several years ago because of this problem with false positives. So make sure you go through this progression. And I was interested, this is still only available online, that's why there's missing a volume there, but this practice in Stony Brook, New York, which is a hotbed of Lyme disease, an adult ID practice, about 1/3 of their Lyme disease referrals were actually false positives. I don't think it's that high around here, but gives you an idea. And it's also confusing. I mentioned I do most of my outpatient practice at Holy Cross, and I discovered just a few months ago they have 5 different Lyme disease tests offered, all going to different labs and doing things differently. So they're, at my urging, are narrowing it down to 1 so that it won't be quite as confusing for the clinicians there, but that hasn't happened yet. So point number 2 under testing, do the 2-tier assay. The other thing that's really tough with Lyme disease, and don't get blown away by all these bars and things here, this was a really interesting study in adults. They looked at patients who had early Lyme disease and then patients who had Lyme arthritis. And the dark bars were when they were tested during when their disease was active. And then they got 10 to 20-year follow-up serologies. And the thing I'll just point out here is how long IgM can persist. Look at the percentage of patients still with IgM bands. And these were all patients who were doing well asymptomatic. I guess you couldn't preclude them having been reinfected recently, but it goes to show you just how tough it is to interpret Lyme serology, especially someone who's been diagnosed with Lyme disease with positive serology in the past and then trying to make sense of a new episode 2 years later. Just because the IgM is positive doesn't mean there's anything new going on. So that's a tough one. I'll mention a couple tests you may have heard of. One is lymphocyte type CD57 cell. This has been touted and still is being touted by the so-called Lyme literate physicians as a key test for Lyme disease. All I can say is, and we'll talk about chronic Lyme a little bit, there's no difference in the results of this test in patients with Lyme disease and sort of chronic fatigue complaints and patients without Lyme disease and chronic fatigue complaints and normal individuals. So it's not at all discriminatory. It has nothing to do with Lyme disease as best as anyone can tell. And then there's the C6 antibody test. That's another portion of the Lyme disease spirochete that's being tested for. And a few years ago, I was hot on this. I thought it was going to be the savior of our testing. And it's still okay. Actually, just this morning, I found out the 2012 Red Book is online. And they actually mention the C6 test, although they're kind of wishy-washy about it, which I think is good at this point. The real question is, could it replace a two-tier test? And I think the jury's still out. So I almost never use it, but if we have some tough cases, I might go to that. But in general, I would stay away from it until it's better validated, both in adults and kids. And that brings me to the chronic Lyme concerns. And I've been through, I don't know how many patients and families with varying degrees of concern for chronic Lyme infection. And I guess, being at the receiving end on the ID specialist, it is appropriate that I see a lot of these kids. And I've decided at some level it's difficult to refute this because it's almost like a religion. Do you believe in chronic Lyme disease? It's not something that can be tested by theory or scientific method because I think it has been tested there and found to be lacking, including doing prospective treatment trials of patients with chronic Lyme disease and showing that, for example, 3 months of antibiotics has no difference in outcome compared to placebo. But regardless, again, the so-called Lyme literate physicians don't use that level of evidence. They don't use the same scientific method we're all used to. Maybe 20 years from now they'll prove me wrong, but there is an astonishing amount of evidence that chronic infection with the Lyme disease spirochete doesn't seem to occur, and it goes away with treatment. And treating for periods longer than a month doesn't seem to help anybody. So I've included a few references there that you can look up on the web. These are the sort of main arguments that the Lyme literate physicians will use. So you'll hear those. They're all over the web. In fact, that when you Google Lyme disease, you're more likely to get your early hits from some of these Lyme disease groups and practices. But if you look closely at their arguments, it's almost like they're on a different planet. I try to maintain an open mind, and I'm always skeptical of any published report, but these guys are out there. They're using a different scientific method. And of course, many of them graduated from medical school in the U.S. and have MDs by their name. So be aware of it, and I think it's difficult to refute. If at some level somebody wants to believe in this syndrome and wants to take antibiotics for a year, it's very difficult to shatter that belief. Another couple resources to mention. This is from the Virginia Department of Health. You can actually go on their website and download a poster for your office. I'm not sure whether you would want to do this or not. Do you want everyone in your office to start thinking about Lyme disease? Maybe not. And this is just an adaptation of posters available from the CDC too. But it gives you, I like this, being an infectious disease, I usually don't have a dime to my name, but if I had a dime, this is sort of a good thing to use if somebody does happen to bring in a tick, which I would, of course, prefer they not do, at least in my clinic. And then these are some resources I mentioned. The CDC is very good, both resources for us and for the lay public. I'll mention the Infectious Disease Society of America practice guidelines. They're free, so you don't have to be a card-carrying member of the IDSA. And not just for Lyme disease, there's a great one from last fall on pneumonia in children. They're as detailed as you want. You don't necessarily have to read all of it, but it gives you some idea of the evidence behind what they're saying. I like it better than the Red Book, although probably lightning will strike me for saying anything bad about the Red Book. Yes, Dan?
In the absence of something like health policy or arthritis, what percentage of kids will have the rash? I heard that kids are much, much more likely to have the rash if they have Lyme disease as opposed to adults. And so can you use that as any method?
Great question. It's sort of two things I wish we had better data on, just because the information is kind of old, and I wish we had local data especially. But it's probably in the 80 to 90% range of children with Lyme disease have a rash, if you ask. I think a lot of those were missing because it is in the scalp, and if they have thick hair, I only wish I had thick hair, but if they had thick hair, it's pretty easy, because I've seen some erythema migrans in the scalp, and it's very easy to miss, and of course it can be asymptomatic. And the other thing I wish I knew was the seroprevalence of Lyme antibody in our area, in children and adults. In Connecticut, for example, at least as of maybe 15 or 20 years ago, it was around 5% seroprevalence. And maybe a quarter of those patients had no history of symptoms suggestive of Lyme disease, and they're perfectly fine. So it's unclear what the rate of asymptomatic infection is. But that's why when we're testing for Lyme disease, you never know, is it a coincidence that somebody tests positive, or is it really related to their symptoms? The question was, is the percentage of adults that have the rash much lower? And I would say, by and large, no. Published studies are a little bit lower, but there's a fair overlap there and among various studies. So if it is lower, it's not much lower. The nice thing, I know the other thing we all get asked, somebody's found a tick on their child, not sure how long it's been attached or whatnot. I'm relatively calm about that, because at least you know where the tick was, and you can watch that area for a rash. And that's probably a pretty sound way to do things. So there are all kinds of issues with prophylaxis. So that's one way to manage that. Michelle, yes.
What do we do with these people that have gone to urgent care, and because of the letter that the Virginia Department of Health sent out, that in Virginia you got a tick, or to the extent of it, I think that you've got a tick they're supposed to be treating, so urgent care is putting them on antibiotics, then they come into our office 2-3 days later already on antibiotics.
Yeah, well, tick prophylaxis, there's only been one study in young children from Yale. So it's a single dose of doxycycline if you're old enough, but you sort of don't want to keep doing that in young kids.
No, they're treating them for the 2 to 3 week duration because of Lyme disease.
Oh, well treatment is tough. But I will say, just back to the prophylaxis thing, for children under 8, the regimen that was tested is a week of amoxicillin, and actually it's sort of, there's only been one study, it's small, but the risks probably outweigh the benefits of prophylaxis. I'm talking about risks of anaphylaxis from a week of amoxicillin, which is pretty low. Well, what do you do when somebody starts a child on Lyme disease treatment and you don't think it's appropriate? Discuss it with the family. And it's tough, I know, on the front lines with you. Sometimes, you know, I'm the so-called expert and I have gray hair and things, so I can make a more convincing argument, but it's tough sometimes. So again, you have to weigh the risks and benefits.
But
yes.
one more question. You over here.
I
brought my own microphone, so
Oh,
ask whenever I want.
resourceful.
Now, you mentioned about the pressure of ordering the test, but we not only get lectured as to why we should be ordering it, but also where to send it. So we don't even have the choice of sending it off to the lab we want. And it's always thoroughly vetted by this Google, peer-reviewed Google research and everything. But a lot of people tell us we got to send it to this lab in California, and they have a lower standard for calling it positive. Can you just comment on that?
Yeah, that's a real tough one. I do draw the line there personally. I will not send it. They're called Lyme specialty labs of varying degrees, and they've come up with their own interpretation of positive or alternative tests, or they use the CD57. I can't send blood on a child to any of those labs in good conscience. So, you know, I would have to refuse personally. Now, are they going to do it anyway? Maybe so. But I think that's just, you know, I couldn't make any decision based on those tests. So it does me no good to send them. It certainly does the child no good. All right, quick, two most common pitfalls in Lyme testing. Uh-oh, you were sleeping. Yeah, testing the wrong disease, not using the Twotier. And I'm always, this is shameless, I don't get paid to do these blogs, but if you Google pediatric infection connection, or if you pull up the slides from the network website and you have a smartphone with barcoding, you can focus on this QR code and it will go right to my website. I write little blurbs once or twice a week. They're pretty painless, less than 30 seconds. And I just mention it because I feel like I'm talking to myself. And it's always nice to know there are a few people out there. And, you know, you could have learned about fiddlehead ferns a couple of weeks ago. All right.
So, Bud?
Yes.
So we're at time. You're doing the next lecture, and it looks like we have at least 4 questions. Do we want to try to move through those real fast?
I'm happy to.
Okay.
I'm sorry, it's like the glare from that, I could see nothing.
It's the paparazzi out here. You know.
Such an annoyance.
I had a question regarding overlapping serologies. I've had it happen in 3 patients that I sent off tests for mono and also for Lyme's that came back positive for both, and they did have mono, but I was told they don't have Lyme's. I had another situation where I had one that had a vesicular rash that was positive for Lyme's, also came up positive IgM for HSV, and I don't know if there was any particular comments you could make with regards to that.
Yeah, this is great. I love EBV. It's so tricky. It's an infection of B cells, you know, the cells that make antibodies. So it can do all strange kinds of things. If you already have B cells geared up, maybe you've seen the Lyme spirochete sometime before in your life, so it will create positivity. There have also been a strong suggestion that EBV can create false positive serologies for many illnesses. So that's a tricky one, number one. Number two, HSV antibody testing, I don't know what I'd use it for diagnostically. It's an epidemiologic tool for pregnant women. But it's not, in the commercial labs, they're supposed to be able to distinguish herpes type 1 from type 2. There's not enough data out there. Trust me, I've tried. calling the commercial labs, asking what kit they use, seeing what the evidence is. So it's not clear that they're specific, and since almost everyone is infected with type 1 at some point, if there is overlap, it's hard to do. So I try to stay away from HSV testing, antibody testing, and just use antigen testing like PCR or DFA from an actual lesion.
Similar question, but two separate cases. One is I had a kid who presented to urgent care with elbow pain and swelling. When they did ASO and Lyme, they both came back positive. He saw ID, and he's being treated for both, for rheumatic heart disease too. But the other case is a kid who had a swollen joint and positive Lyme's, was treated. 3 months later, had another same joint swollen. And is that a recurrence, or is that a new infection? And how would you distinguish between the two?
That's great. First of all, my faith in ASO was shattered 2.5 years ago from an article in Clinical Infectious Diseases that showed all these things that we thought were true about ASO and anti-DNase B rising and falling with infections and things like that. None of that works.
But had cardiac findings too.
Yeah. So a single ASO titer is not going to help you at all, and maybe even serial titers won't help you. But that's a tough one. And clearly there's post-infectious or post-strep inflammatory arthritis, different from acute rheumatic fever. With an arthritis, with no other etiology, if serum antibody is positive for Lyme, then you're going to treat for Lyme. There's no way to disprove that, or no easy way. And, there are PCR tests for Lyme, but they're extremely insensitive. So sometimes in cases where they're difficult and we're getting joint fluid anyway, I'll send a Lyme PCR, but they're almost always negative, and I'm still stuck treating. The child who gets, the standard Red Book treatment for Lyme arthritis and then and resolves and then shows up 3 months later with renewed joint swelling might have JIA. And there is no good blood tests for juvenile idiopathic arthritis, but that's the time where you got to start thinking about alternatives. And those are the kids where I might be more aggressive about getting joint fluids and PCRs and thinking about all that. Yes?
Okay. I just have a quick question. I wonder if there's anything on the horizon for vaccines for Lyme.
Oh, great question. Lyme vaccine, do you all remember there was one? And that was going to be the great thing about the C6 antibody test, because the regular antibody tests would turn positive after vaccination, but C6 wouldn't. But then there were concerns about, and I still don't know what to make of it, some of it seems plausible, that there might be an association of arthritis with the Lyme vaccine itself. It wasn't out there long enough to really know anything. And essentially, the company couldn't make any money. It wasn't, there wasn't long-lasting immunity, so somebody living in a Lyme endemic area would have to keep getting re-immunized. People are still working on it, but I haven't seen anything approaching phase 3 trials yet for vaccines. But that would be nice. Dr. Einhorn.
Yeah. When I was in medical school in France, and that's about 100 years ago, there was in the literature there were reports on erythema migrans, and both in the French and the German literature for years, and they always pointed out it's a benign disease, not an asymptomatic otherwise. Have you any idea what that might have been, and whether the tick has finally reached Europe and have also given Lyme disease or whatever, Marseille disease or something like that?
Well, fortunately, I was not in medical school 100 years ago. It was only 90 years ago, so that probably just barely preceded me. Actually, Lyme disease was in Europe, recognized in Europe before the US, mostly in Scandinavian countries, and there's some minor differences. There are different Borrelia strains that are active there that actually won't be picked up with the regular antibody testing, but will be picked up with C6. So if I've had somebody that's traveled to Norway and had a rash over there, or Switzerland, things like that, then I'll start thinking about that. So it could well, that's interesting, it could well have been that, and maybe, I don't know exactly when it was described first in Europe, but it might have been the real thing.
Does it continue to be described in Europe?
Yes.
Okay.
Mm-hmm.
Thank you.
And the WHO monitors activity, obviously worldwide, of that.